So thank you, Dr. Theriault, for giving us a talk here on choosing wisely.
So hi, everybody. So I guess I'm at the chief's table. Is that what you call that here?
Medical Advisory Committee, yeah.
Okay. We call that table des chefs in Quebec. So yeah. So like I said, I'm a family physician from Gatineau, and I'm on the clinical leaders group of Choosing Wisely Canada. So that's why I came here today to present Choosing Wisely. Do you know about Choosing Wisely? Who has went to the website? Okay, this is quite interesting because on the Quebec side, that's not the answer that I get. So it's quite interesting. So the objectives today are to introduce Choosing Wisely campaign and to show you what you can get from Choosing Wisely, to provide practical information and tools to implement and measure Choosing Wisely campaign in your practice. To present the efforts that Choosing Wisely Canada makes to educate and engage patients, and to describe other areas of focus of Choosing Wisely just at the end, just to open up and tell you what they're doing also beside all of this. Is that okay? The sound?
Whoever's on open mic on the phone, can you just mute, please?
So I don't know if you've seen this JAMA article in 2012, and there is a lot of focus on waste in healthcare. We have known for many years that in the US, for example, about 40% of the expenditures of healthcare are total waste. I mean, they don't add any value to the patient. In Great Britain, it was thought to be about 15%, and CIHI in Canada has measured this waste at 30% of all the expenditure that we do. So it is huge and humongous. There is a lot of kind of different waste in healthcare. So you have failure of care delivery, care condition, and so forth. But overtreatment and overuse is a big part of waste in healthcare. And Choosing Wisely is a kind of a tool to try to address this big, huge problem of overuse. And even if we put a lot of money in our healthcare systems, we don't get as much back as what we had put in the systems. And this is one of the survey that was found. There is others about OECD countries around the world. So it's not something that is just like a problem that's going to go away if we don't do anything about that. So it is hard. It is hard to change culture. It is hard to change physicians' behaviors and healthcare professional behaviors. Why is it so hard? Because there's a lot of things that is on our minds. We want to do the best for the patients. But I will focus on this thing here, because this is something that is addressed by the Choosing Wisely campaign, and this is something that I see every day, every time that I teach, every time that I talk to people about that. The feeling that it's better to do something than to do nothing. The feeling, well, it can do no harm. Well, just in case. I'll do that just in case. And this is a big driver of overuse. Okay. There is other drivers. We're not all responsible for overuse, but this is one of the big drivers. And this is all the other things also that can influence you, the fear of getting sued. Well, I've always done this like that, so and it went okay, it was fine, so why should I change? The patient wants it. Well, this is something that we could talk more about, but the patient wants it is one driver of overuse, but sometimes it's because we don't have the discussion with the patients. And then when you have this discussion, then what they want is really different from what they came up with. So Choosing Wisely Canada is a campaign to help clinicians and patients engage in conversations about unnecessary test and treatment and make smart and effective choices to ensure high quality care. Choosing Wisely Canada is not to save money. It is not recommendations so we will spend less. It is recommendations so we will spend more wisely, and we will do things that gives value to the patient and decrease the things that don't give value to the patient. What is unique about Choosing Wisely? It is clinician-led. So a clinician talking to a clinician, it's more easy to have the message go through than if it comes from above somewhere. So it is, and it will continue to be clinician-led. It is a bottom-up approach. You probably know about the list. This is the first thing that Choosing Wisely came up with, all the list, and I'll show you example later on. But this came from physicians on the ground. It didn't come from high authorities. It is focused on common clinical conditions. It's not something esoteric, it's something that you do. Many of the recommendations are things that you do every day. And it tackles primary care and specialties, both. And it is simple. That's not to say that it's simplest. It is a simplest, but it is a simple way to try to do something different in our clinical practice. The principles, I already told you that it is clinician-led, and the key message in every recommendations is that we should have increased quality and we should decrease harm. Because doing more and doing more again, it is a barrier of harm for the patients. And that, we don't see that. We don't realize that. Well, we have all of our examples, but we don't integrate that in our practice. It will and will stay patient-focused because the conversation is central. Shared decision making, it's not that talked about in Choosing Wisely, but it is central to what Choosing Wisely recommendations are. It is based on evidence, it is updated all the time. It's not only for physicians, it's for caregivers, and it is transparent. So the approach has four groups that they tackle. They want to tackle the clinicians, the patients, the media, and the stakeholders. The clinicians, well, there's those lists that are provided to clinicians that you can use to have ideas of what you can change in your practice, in your setting. The patients, when there's something interesting in the list that is very, that we can translate into patient communication tools, well, it's done. They develop patient materials associated to the recommendations. They have a lot of presence on the media. And I'll show you later, the next slide, different ways that you can share not share decision, but clinical tools and articles about choosing wisely through social media. And what is kind of not new, but a bit different in Canada is that they wanted to go further and they wanted to help people implement the recommendation and just say, well, you should do that, but how? And we'll give you example and we'll help you do something like that. So they worked with the healthcare stakeholders. So Choosing Wisely Canada is all of this. So you have the list. There is more than 50 societies now that have provided lists. Some of them have provided 2 lists. There is, yes, contribution. There is a lot of presence on the social media, like, for example, Twitter, but also Facebook. And I'm amazed at what they put on Facebook. It is quite interesting. If you don't follow them on Facebook, do follow them. And I share that and to my friends that are patients, and I have these feedbacks that are very, very interesting. So they have a lot of presence on social media. They have these do-it-yourself toolkit that I'm going to show you. STARS that I'm going to talk to you about just a little bit about reaching medical education too, because we have to start with medical education and all of this. So it is just one thing. It is not just a list. It is like a complete package. So who here has successfully stopped a treatment? Yeah. Or said, no, you don't need this test, and the patient was happy. Yeah. Or I just said, well, okay, I won't order that test, or I won't order that treatment because I know it's a low-value treatment. So this is something that is done more and more, and this is something when I teach residents and Susan that they really get. But this is something that we have to change for many of us. So this is an example of the list, and there's many, many lists now on the website, and you can have the recommendation with a short description of the recommendation and the reference if you want to go further and read further about it. You've seen those lists, so you know what they're kind of like. And the list, they make recommendations on tests, mainly like 53% are on tests, treatments, and a little bit on procedures. Procedures would be like surgeries and things like that. So who has taken a recommendation and tried to implement it? Okay. So we'll share maybe some of what you did and what happened. So it's the hard part. It is the hard part. You can do it for yourself, but when you try to implement it on a wider, like a clinic base or an hospital, it is not easy. Changing culture, and believe me, I'm trying for years to change culture in my setting, it is not easy. And the implementation scale, there's many things you can do. There's a low leverage thing, and well, it's not bad. You can do some clinical education and patient education, yes, but you can go around in your clinic and just teach about one of the recommendations and then try to see if that changes something. For example, the PPI recommendation, which is to lower our prescriptions of PPI, we did something, me and the pharmacist in our clinic, we did something, we taught the clinicians, and now we're doing an audit and feedback to see, well, did it change practice? Was the tool used properly? How did they feel doing this in their practice? This is one example. So you can do performance measurement, quality improvement projects, audit and feedback, or you can go like very hard and code the thing. Like in our settings, there are things now that you cannot order. You can order them, but you won't get the result. Okay? It's so simple like this. So it's very hard coding there. So it depends where you are and where you start, and it depends on the recommendation too. So the same plan can be different depending on the recommendation. So do you know about the toolkits? Choosing Wisely Canada has gone farther than just providing a list. They wanted to give you do-it-yourself toolkits. Why? Because they realized that people were doing things. People were changing things. They were taking things that were on the list and they were making it happen in their settings. And they said, well, if you're able to make it happen in your setting, maybe I can learn from what you did, what went well, what didn't went well, and then I can try to replicate it in my setting. And one of the hospitals that has been very successful in implementing is the North York General Hospital, and you can see the results here. Emergency department lab testing down from 31%, pre-op clinical lab testing down 38%, inpatient 12%, and chest X-ray in ICU by 12%. This is impressive. Okay. And this is with increasing quality of care. This is not decreasing quality of care. And once you save money with this, you can then maybe augment your quality of care and do something else with the money that you save on on things that were not giving value to the patient. So these toolkits are very simple. There's user generated. You can do a toolkit. You did something. Some of you raised your hand just before, so you did something. It went well. It didn't went well. You want to share it with other people. You can do a toolkit. Authors. It's short, simple, practical, and it's a living document. Then you tried something else, or you realize, well, these stakeholder I didn't thought, and when I went to them, then it's when it started to be feasible in my setting. So there is many, not many, but a few, and I'll show you them all, the do-it-yourself toolkit. There is the one on blood transfusion, and it was used in Sunnybrook, Toronto, decreases their transfusion by 29%, Nova Scotia 16%, and it is always written with no impact because that's the reality. In Alberta, they tackle the antipsychotic and prevents why they have a decreased of antipsychotic use of 8%, and the early adopted sites are down to 50% less antipsychotic medication that they use. In Sunnybrook, the catheter use on the ward was something that they wanted to tackle, and they were successful on reducing the use of urinary catheter on the medical wards. Bye-bye PPI, that's the one that I'm trying to tackle in my clinic, and they they did, and they were able to decrease PPI use by 26%. But what more is they were able to engage in discussion with 93% of the patient about the PPI use. The hypnotic, sedative prescriptions down by 40% in Sinai Health System, and the pre-op lab testing down by 38%. These are all examples of people that, like you, were just like, they had a good idea, they saw the list, they took that and say, well, how can I do that? They went about and did it, and they shared their experience. These are the do-it-yourself kits. There are also, and it's kind of new, so I didn't have the chance to listen to them, but there's the Choosing Wisely talks. So I guess they're going to be once every month or every 2 months. And these are people that will share what they did and their examples of what happened in their settings. So the key ingredient in the toolkit are the key ingredients of the intervention, how to measure what you're doing, how to sustain early success. Because sometimes, you know, when we did the talk about PPI, I think within the week or 2 weeks after that, everybody was talking about PPI. I'm not sure they're talking so much about PPI now. So how can you sustain that? And then there is additional resource depending on the toolkit. So this is a way that Choosing Wisely Canada goes further than just giving you the list to try to help you implement the recommendation on the list. So on the website, you have all those toolkits. You can look, there are some workshops there, changes, other ideas that are not really put into toolkits, but that can give you ideas, and they will give you example of what they did or how they came about to choose that recommendation to do something in their setting. So we have to implement things, but it's interesting to measure also what happened. So what can you measure? You can measure, yes, if the overuse decreased, so if the red blood cell transfusion decreased, but you could also go and measure the attitudes and the awareness of the physicians or the attitudes, perceptions of the patients. You can go and measure that. And Choosing Wisely Canada has gone around in Canada to see how, and this is family physicians now, about attitudes and awareness of the campaign in family physicians across Canada. And it's very interesting to see that 91% of family physicians agree that patients will benefit from Choosing Wisely recommendations. They agree, most of them, that one of their responsibility is there in ordering the test. And they also think that patient drives inappropriate care, which is something that may be true, but like I said, when you have the discussion, you change the perspective of the patient often. Who has heard of the Dartmouth Atlas in the United States? Dartmouth Atlas. The Dartmouth Atlas is something that started in the northeast of the United States. It's now widely in the United States, and it has shown us that there's 3 different kinds of care. There are effective care. So if you come in the ER and you're bleeding from everywhere, an IV is a good thing. Okay, this is an effective care. But there's a lot of care that are preference sensitive care. So you won't make the same decision as I will. Like regarding cancer treatment, maybe if I'm 90 years old, or if you're 60 years old, or if I'm very sick or not. So they are preference-sensitive care, and that makes a lot of what we do in medicine. And there is the supply-sensitive care. The supply-sensitive care is that if you have a second CT scan here, you'll do more CT scan. Okay? It's not because you're mean, it's not because you're greedy, it's just the way it is. And until we really show that to people, they don't realize that they're doing things out of habit or doing things just because it's available. And this is a measure of overuse that you can see in the Dartmouth Atlas, but that has been done in Canada, in Ontario, for the ECG and pre-op testing. And you can see that depending where you are, some hospitals do like 5% of ECGs in their patient, and some is up to 70 and 80%. Nothing can explain that. It is not because one hospital has more old people and sick people. Nothing can explain this wide variation, but practice and availability and routine. So once you know that, then you have to, maybe it's okay to do 80%. I don't know, but it's a way of reflecting on overuse. And this is other variation that have been computed in Ontario about imaging for low back pain, cervical cancer screening, and DEXA scan. The variation is a bit less, but the variation is there too. And once you see that and you have those data, then you can reflect on your practice. So CAIHI is measuring a lot of things in Canada, and preoperative testing, antipsychotic, screening, mammography for 40, 49, low back pain imaging, head CT, benzodiazepine, and so forth. And there are more and more publication on the topic. This is a few of them. There were others also before, but it's interesting to read about those, because then you realize that overuse is not just a small problem. It's a big problem, and then we have to tackle it. So you can also measure, so we say we can measure overuse, you can measure physicians or private perceptions, you can also see what the patient thinks. And I think it's quite clear that the patients, like physicians, know something is wrong, know that there's a lot of unnecessary things that we do, and they do believe that. And they, up to one patient in 4 has said that once it happened that they had a recommendation of a test of a treatment that they felt, well, is that really necessary? And what did they do about that? 25% took the test anyway, 31% didn't take the test, and 44% felt empowered to talk to their physicians about is it necessary or so. And this is one of the goals of the Choosing Wisely campaign, is to empower the patients to be able to talk to their physicians about is it necessary or not, this treatment or this procedure. So further results, you see here, there is concern that maybe if we limit things, we will limit also things that are pertinent. So this is all in the discussion again. 92% believe that they need more support, they need more tools, they need more information to be able to make good decisions. They believe that the decreasing in inappropriate use relies on your hand as physicians, and they are not that much aware of the Choosing Wisely campaign. So you can refer patients to the Choosing Wisely campaign. The website is very accessible. There is a website for clinicians, a website for patients, which is done a bit differently. So lastly, just to say that when Choosing Wisely focus the patients, they have, like I said, the social media, and they have campaigns. And the campaign now is really focused on the thing, more is not always better. Yeah. You've seen that, maybe you've seen the clothes washing machine also, where there's too much soap and it bubbles up. So it speaks to the patient that more is not always better, and the message is to say, it is the same thing in healthcare. It is the same thing in medicine. More is not always better. Okay? So it's to educate them about what they might need or might not need, a test or treatment, and mainly encourage them to talk to the doctors about that. And once they open the discussion, then it's easier. It makes it more easy. About these 4 questions. This is the 4 questions that are on the website. There is a poster about them to encourage people to open the discussion about test and treatment. Do I really need this test, treatment, procedure? What are the downsides? Is there anything else I can do? Are there other options? What happens if I do nothing? This is all valuable questions. And I have a friend in my practice that's she's a very high prescriber. She prescribes a lot. And then I had this thing, and I say, well, you can turn that for yourself too. You can have that in your head too and say, do I really need to order that test? Will it change something? Can I just wait a bit and see what's going to happen? What happens if I do nothing? Okay? So you can change that and use that for yourself too. So many tools are available in the website for patients, and they're usually set up in very easy, quick, short format, so they have the information that they need. You can use that to give it to them. You can leave them in the waiting room. You can do many different things with that. On the website, you have these videos. Mike Evans, maybe you know about him, and he does these videos, and so you have that. And yeah, on the media front, we also, I mean, Choosing Wisely also wants to have a presence on the media, the general media, so that the people are aware of what's going on in other fashions and to have to go to the website. So they're really trying to tackle different ways to reach the patients and to reach physicians. So lastly, just as a quick thing, like I said, they want to tackle physicians, patients, they want to help stakeholders do something, but they also, Choosing Wisely Canada is also focused, has a focus on medical education. And medical students can be something that, do you have medical students here? Yeah, so you can use them to do those projects. You can use them to have those ideas. And they are very refreshing. When you go into these conferences and you have all the students and they have all those ideas, they have so much energy. And there's the STARS program, and some of your students can be part of the STARS program. These are all the students on the STARS. They made their own lists. You can read that list if you want. They made their own list, and they're a good vector of change, and you can use them to change things. Lastly, just to tell you that Choosing Wisely is not only in Canada, it's everywhere in the world. I don't know how many countries now have Choosing Wisely, but it's as many countries, and they now have a forum, an international forum. They meet every year. Choosing Wisely Canada is there on that forum and sharing experiences and getting feedback also from other countries to maybe help their campaign, but also share ideas. So this is what I had to say about Choosing Wisely. I hope that you're using Choosing Wisely, and I hope you're trying to do something about Choosing Wisely. I know it's not easy. I've been trying, and I've been successful sometimes and not successful other times, but I think the key message is Choosing Wisely is a tool, but we have to do something about overuse, and we have a particular power as physicians to do something on overuse. And Choosing Wisely is one of the tools that's there to help. Do you have any question?
How would you apply Choosing Wisely to Titus Media and kids?
But you can look at the recommendations, but depending on I don't know all the recommendations by heart, but depending on the recommendation, then you can have tools to share information with the patients. You can either have them in advance or there in the waiting room. There exist shared decision-making tools to speak to the parents of kids about, well, what happens if I treat the patient? What happens if I don't treat the patient? And then they see that there's not that much difference, and there are side effects. So you can look in the internet. You're well aware of the HORI, the Ottawa Hospital Research Institute. They have many decision aids there. I'm sure they have on Titus Media, and you can implement that in your practice. So that's one of the ideas.
Titus Media is one of the ENT Choosing Wisely recommendations, as per the recently published guidelines on the media in children. And so just using the toolkits and printing out some pamphlets and stuff is probably one way to start doing that, and having that conversation that not all kids need antibiotics. Yeah, but that's a tough one. It's just like the other one you put up there, sinus problems. You know, that's another common ENT thing that gets overtreated.
Yeah,
so.
It is. But I think if you start with one thing, and then you have success in one thing, then you will want to do something else.
The back pain one is the one I've used the most. Because everybody wants an x-ray for their sore back. And so it's a very helpful toolkit. Patients are still driven by not even necessarily their own or some other clinician. Their friends and family say, well, you should have an MRI. You've had that pain for 3 weeks.
Yeah.
So it is a long conversation, and it does increase clinician time. But
it probably saves you time. You
Yeah.
You don't have to follow up on that MRI.
And the thing is, so often when you ask them, what do you think the MRI will help you? Why? And then they say, well, because you're going to know what I have. Okay, well, is it going to change something? What am I going to do? oh, you won't change? What? Oh, okay. So then they realize that it's maybe, so it can be a very long conversation, but it can be, you know, when you get the use of it, it can be shortened, and then they realize, well, yeah, maybe there's no plus value for me to do that test.
One of my bugaboos that we tried to do, particularly in long-term care, is treatment of asymptomatic bacteriuria in the elderly. And unfortunately, the flip side of that is somebody who's old gets a weak spell, they end up in eMERGE. eMERGE can't find anything. Oh, there's bacteria in the urine. Oh, it's probably a UTI, prescription, home. And it's a quick tool to psychiatry, yeah, geriatric
Medication,
sites
yeah.
won't see someone unless they've had a negative urine. Because it's, for them it's a UTI until proven otherwise. So, you know, I don't think the geriatric psychiatrists have a choosing wisely. They may have one on antipsychotics, but they don't have one.
So what you can do is you can have, so say your choosing wisely is not treating bacteria. And then what coming out from that in your project to tackle that may well be separate projects to address the site guide and say, you know, these people turn up, we need that urine. And so those can all be separate projects that eventually lead up to your big project of trying not to treat those patients. So
For example, the group of breast radiologists themselves all recommend screening mammography between the ages of 40 and 49 routinely, right? So that's a whole department. And so, you know, that family physician or, you know, what are they
We had
doing
a talk
in the
here
face
about
of that? So they have to change within, you know, embrace those recommendations, and there's a lot of resistance.
yeah.
Um,
And that's the problem, not everybody's at the same place, right? And everybody has to catch up, and if we can all get on the same train, then that works better. But I think that's where the difference
It's a change of culture and culture of many. If you can change yours, but you have to change everything, and this is the hard part. And it's not because it's not on the list that you cannot do your own recommendation and then try to apply it. Because if you, the lists are the start of the thing, but they're not the whole thing. You know, it's just to get the idea that there's things that we can do less or we can do better. So, yeah.
They estimate, I think, there's so many nurses who work in long-term care. One of the things that they routinely do is check urines, regardless of whether there's an order or not. So we started to say, if you want to do a urine, you need to get an order. And they paid attention to that for at least a month.
Yeah. So it's not only physicians; it's the workplace also. So it's other professionals that are with you. Yes, of course. Yeah. So if you do implement things, if you do things, I encourage you to share it. Either like just register to do a talk, and just, you know, if it's too long to write everything up, you can at least, you know, give that, or write a very short summary that can be on the website, or even make a do-it-yourself kit and say, well, we tried that and it didn't work until we thought of, you know, getting the nurses on board. And when we got the nurses on board, and then, you know, something like that. So, and it's like that we're going to be able to implement more projects, is by knowing what other people did and what worked and what didn't work.
So just a question, I haven't been to that part of the website. Toolkit itself, is it just like downloadable templates and stuff that you just populate with pictures and text, or you have to make it from scratch? Because I saw all those posters look very similar.
Yeah.
They all had the thing and a picture and then the title. So is that like a downloadable?
I'm not sure about that. I would have to inquire, but I could get back to you on that. I'm
That
not
would be
sure.
cool. You
Yeah.
could just, you know, switch the picture around, change the text.
Yeah, I'm not sure.
And then publish your own poster in the hospital. Or whatever.
I'm not sure that but they're kind of similar. Yes, they have the same structure. So yeah.
Any other questions for Dr. Theriault?
Okay, so don't hesitate to share what. Yeah.
Here?
I just had a quick question about the QBP handbooks that are released for each quality-based procedure. Do they incorporate the choosing wisely recommendations?
Which handbook?
The quality-based procedure?
No, they don't.
They don't?
Okay.
These are random government stuff.
Yeah, and they actually cover
Completely.
too much, and that's where we have found,
Over.
making best practice, pre-printed orders and following the best practice, where we're running with COPD and that, the amount that is ordered, so that's what we say with COPD, how we thought that every patient that came into eMERGE that had COPD, you order this, but really it should be the ones with exacerbation, not the CTAS 4s and 5s, because the eMERGE doctors are saying, well, if we order this is really going against choosing wisely, because it's ordering so many meds. or so many
QBPs
pills.
almost have nothing to do with evidence-based medicine, it's just purely trying to save money for the Ontario government, that's what it is.
But-
Trying to get people who are not doing things well or efficiently to get other people to do it, basically. It doesn't have anything to do with best practice.
But just at the, I don't cannot answer exactly your question, but just go with the low-hanging fruit at the beginning.
Yes.
Just go with something simple, easy, and then you bring success, and then you go further. Because if you want to tackle a big, even a very easy thing in my setting, it's hard. So it's been a year and a half that I'm trying for the X-ray back pain thing, but we'll get it somehow.
Okay, well, thank you
Okay,
very much,
okay.
Dr. Theriault, for coming to talk to us.
Okay.
Thank you.